Thank you very much for joining us. A very warm welcome on behalf of the IAPB events team. We're very much looking forward to supporting you with today's Focus on Glaucoma webinar, Affordable and Sustainable Care in Southeast Asia. We'd like to open with a few housekeeping notes before handing over to Yuda Sapkota, the IAPB's Regional Coordinator for Southeast Asia.
Welcome to you all in the IAPB Focus Glaucoma webinar as a part of the Celebrating Glaucoma Week 7 to 12 March 2021. Thanks to all the speakers who kindly accepted our invitation despite their busy schedule to share their expertise in glaucoma management. Once again, welcome to you all. As we know, glaucoma is estimated as the fourth largest cause of vision loss globally. There are limited data available on glaucoma prevalence and the risk factors. As a disease prevalence survey for glaucoma are not commonly done in many countries due to its complexity of the diagnosing in field setting. Glaucoma detected in a blindness and visual impairment surveys are usually the absolute ones, the late stages, which are irreversible conditions. According to the limited data available, it is estimated that there are almost 8 million people globally are affected with the glaucoma. Of these, 3.6 million are blind and 4.2 million moderate to severe visual impairment, including visual loss. For every person that experiences vision impairment and blindness from the glaucoma, there are many more, estimated 2 to 3-fold more, living with the early stage glaucoma who need comprehensive and integrated people-centered eye care service to prevent vision loss. Glaucoma is an important eye disease that is often neglected by the eye care planners. Many people with the glaucoma are not diagnosed until they have a permanent vision loss. Prominent issues of the glaucoma care in low-income countries, low-income settings includes lack of awareness, no timely detections, barrier accessing the surgical service, lack of local resources and expertise, direct and indirect costs, adherence and compliance to long-lasting and lifelong treatment regimes. In this IAPB webinar, we'll showcase the successful example and awareness in glaucoma, early detection, and how local product development can improve the affordability of glaucoma services in low-income setting, so that the people will have a better access and compliances with the glaucoma management. The example showcased will be highlight the value of partnership in developing local sustainable solutions. For this, we have a speakers, Ravilla Duraswamy Sriram, Joint Managing Director of the Aurolab, India, manufacturer of the high quality ophthalmic consumable, including their famous intraocular lenses. Sriram is an engineer and MBA and has been part of the Aurolab founding team. He will be talking on Aurolab Drainage Device and an innovative solution to obtain better compliance in medical treatment of glaucoma. Other speakers are Professor William Morgan, a glaucoma specialist with a PhD in optic nerve physiology, Managing Director of the Lyons Eye Institute, and Professor of Ophthalmology at University of Western Australia, talking on his innovation and effectiveness of Octarian drainage device on glaucoma. Dr. Indira Paudyal, glaucoma consultant dealing with the both adult and pediatric glaucoma cases in Nepal. She is Assistant Professor, Tilganga Institute of Ophthalmology, Nepal. We'll be talking on the successful example of the glaucoma awareness services in Nepal. Dr. Rashima Asokon, Assistant Professor, Elite School of Optometry, Head of the Occupational Optometry Services. She is a Senior Optometrist and a Researcher, Glaucoma Project, Medical and Vision Research Foundation of Sankar Netralaya, Chennai. She will be talking on the successful example of the early detection and community model of the glaucoma management in optometry perspective. We have a Suresh Pattathil as a General Manager of ABBI India. Allergan is a part of the ABBI. Allergan is an IAPB partner in many of the IAPB action advocating eye health, particularly the glaucoma campaign in South Asia and Africa. He has kindly accepted to deliver concluding remarks and the thanks for the sponsoring this webinar. With this, we have a very tightly scheduled for this webinar. I would like directly go to the inviting the speakers. First to the Mr. Sriram from the Auro Lab for his presentation. Mr. Sriram, please.
Thank you, Mr. Subkota. So I am from Auro Lab. Today I'll be talking about the steps that we have taken as an organization to bring affordable solutions for glaucoma management. The challenges in treating the glaucoma when we use the old generation eye drops, the patient has to instill the drops 2 or 3 times a day, and this leads to some sort of a non-compliance. Because of this usage, when the bottle gets exhausted, sometimes the patient may not have access to the nearby store. So thereby there are chances to discontinue the medication for a few days. The new generation drugs needs to be instilled only once a day, like latanoprost. But these drops are developed in the West, matching their economic conditions. This needs to be stored in a refrigeration. Typically, if you take the developing countries like India and other countries, many households may not have a refrigerator. So to use the modern drugs, we have to find some means to store it in room temperature so that it can benefit all the patients, especially those who are in developing countries who otherwise can't afford a refrigerator at home. We are also trying to develop a dispenser whereby we can avoid wastage of these costly drugs. So that is under development. When the eye drops is not sufficient to manage the glaucoma, the surgical intervention is the last option. The Western-made implants are quite expensive, not in the range the common man in developing world can afford it. So that is also an area where Auro Lab addressed it. Next slide, please. As I mentioned earlier, the old generation drugs needs to be instilled like 2 or 3 times. The latanoprost, after it came to the market, that became the gold standard, as it can be used only once in a day. As I mentioned, it needs refrigeration. So we worked on this issue of both storing at a lower temperature. So we developed a drug which can be stored in room temperature. Also, we address the cost of the drug so that it becomes affordable for the common man to buy it. Next slide, please. Auroprost RT is the brand name, and then this is the solution from Auro Lab. So it is proven efficacy and sustained long-term IOP control, and we developed it in a manner that it can be stored in the room temperature. That is why the name called Auroprost RT. And then we also put them in a 4 combo pack, and then we have priced it lower. And this pack is available only in the hospital. So this makes the patient to come back to the hospital to get his eyes examined, and then get this combo pack and then go back home, which he can use for 5 to 6 months. So this works out well for the patient in terms of economical offering, and also have his eyes checked by the doctor at least twice in a year. So now we are trying to work on a dispenser where we can try to reduce the wastage. So this eye drop addresses all the issue with the storage temperature, cost, and compliance. Next slide, please. So when it comes to surgical treatment, trabeculectomy continues to be the gold standard for surgical management of glaucoma. The glaucoma drainage devices are integrated when trabeculectomy has failed in certain situations like secondary glaucoma, where trabeculectomy has high failure rates. So the option is to go for surgical implants, and they are available in valved and non-valved versions. And then implants, those are made in the Western countries are quite expensive. So the developing countries, were not able to. The patients from the developing countries were not able to afford it. And this is an area which Auro Lab addressed with an implant called RD. Next slide, please. So Auro Lab aqueous drainage implant, shortly called as ADI, is a non-valved glaucoma implant manufactured by Aurolab. It is very similar to Burwelt implant model BG101350, but the material is a bit different. So we made all the biocompatibility studies, and then we proved the material for the patient safety. And then it is a most reliable and affordable product. We have priced it somewhere around $30 to $40. Depending upon the country and the import duties and taxes, the price could vary in different countries. It could be different. Next slide, please. So we are providing this with a large surface area of 350 mm², and then recently we are also trying a smaller version for pediatric, 250 mm², and then this is under clinical trials now. This material is radiographic material, and then it is also affordable. The price, as I mentioned, is lower priced, and then there are many articles are published, and then the RD is there in the market for the last maybe for a decade. And then it is also available in many countries at this point in time. It is available in almost 100+ countries. Next slide, please. So using a non-valved device, there is a greater IOP reduction and the success rate is quite high. The number of resurgery is less. And of course, the medication is less when compared to a valved device in the long-term course. Next slide, please. So there are many articles that has come about RD, and they were all published in leading journals like British Journal of Ophthalmology, American Journal of Ophthalmology, Journal of Glaucoma, and Ophthalmology Glaucoma, and also Indian Journal of Ophthalmology. Next slide, please. So this is the continuation of the many articles that got published in the recent times. Next slide, please. Thank you. So if you have any questions, I'll be happy to answer.
Yeah, thank you so much, Sriram, for your wonderful presentations on the affordable medical treatment, which is one of the issue, and then the implants. I think that we'll take the question later after the presentation of the William Morgan. So now may I invite to Bill Morgan for his presentation, please.
Oh, thank you. Thanks very much. Sorry, I've got a problem with my camera and I don't know what's happened to that. Could you bring up my slides? Yeah, thank you very much. I was very interested to hear about Aurolab. We started this work about 10 years ago, before there were any cheap glaucoma drainage devices. And I've been working in Indonesia for a long time and have a lot of friends and colleagues up there as well. And I had a delightful young, next slide, thank you very much. A delightful young ophthalmologist who wanted to do a PhD with myself about 10 years ago. And we already knew about the problem. In Indonesia, blindness is quite common. It's about 2% of the population are blind. And there are estimated to be about 330,000 people blind from glaucoma in Indonesia. And interestingly, if you have angle closure glaucoma, you're more likely to go blind than if you have open angle glaucoma. So angle closure there is really quite aggressive. Next slide, thank you very much. We were teaching and doing a lot of trabeculectomies in Indonesia, but they had quite a high failure rate, a significantly higher failure rate than in a Caucasian population, which is like we have in Australia. And I started teaching and doing glaucoma drainage devices in Indonesia using either the Barvelt tube or the Multino tube, but they were very expensive at about $1,000 US each. And so Dr. Werner Octariana and myself discussed this problem, and we decided to try and build a cheap, affordable glaucoma drainage device, which could also be easy to insert. So there was the cost issue, an effectiveness issue, and also a technical ease of use issue. So next slide, thank you very much. So you'll see the original hand drawings that we drew up. The main thing was that we didn't want the surgeon to have to sling muscles. We wanted simply a corneal fixation, a small limbal incision, and then to be able to slide the device into the whichever quadrant they wanted to insert the drainage device into. And we also wanted it to roughly match the curvature of the typical eyeball, and have a surface area of about 225 square millimeters. Next slide, thank you very much. So we did quite a number of rabbit experiments, and we used the materials of polymethyl methacrylate, which is very cheap, and also silicone tubing. And polymethyl methacrylate, or PMMA, had not been used before for a glaucoma drainage device, but it's used a lot in intraocular lens manufacturing. We partnered with a company in Indonesia making PMMA lenses, and so they formed the prototypes for us, and we did the rabbit experiments. And then we showed that it was tolerated biologically with the histological review of those animals. So they were sacrificed at time points out to 6 months. And we showed that the histological inflammatory reaction was about the same as for silicone and polyethylene, which is used in a Multino tube. There were no significant differences. So we then arranged for ethics approval with the health department and the University of Indonesia to run a small clinical trial. Have the next slide, thank you very much. So the University of Indonesia approved this in 2016, and we did some blind patients over about 6 months, watched them carefully, and then we increased the numbers gradually, and now it's actually about 1,000 have been inserted across Indonesia. And we also started training other surgeons within Indonesia to do this, and Dr. Aktariana has done the lion's share of all of the training for surgeons, not only in Jakarta, but also in parts of Bali, Sumatra, Sulawesi, and other parts of Indonesia. And I'll show you some of the results. We've published on the material side, and also on the animal results. We haven't yet published on the human results. So if we'll have the next slide, thank you. I think the graphs show the figures better. So typically these patients have got very bad glaucoma. They're on multiple medications, and their preoperative pressure on average was about 37 millimeters of mercury. And they've been followed out to 2.5 years now, and they've generally done pretty well. You'll see the numbers are dropping off. We'll have the next slide, thank you very much. And the medication usage has also dropped from about 4 medications pre-surgery to 1 or so post-surgery. So a lot of saving in terms of medications, and a lot less problem and hassle for the patients. Next slide, thank you very much. We're just starting to review the data in terms of subtypes of glaucoma treated, and you'll see that the angle closure glaucoma subjects, we don't have many patients in that subgrouping, so the data doesn't look particularly good, but mainly that's, I think, because the numbers are so small. And have the next slide, thank you very much. So all of the human data was reviewed by the Human Ethics Committee of the University of Indonesia in 2019, and then it was approved for use by the health department in Indonesia in June and officially launched in June 2019. And the cost is about 100 Australian dollars, so it's probably about 70 US dollars equivalent, which is much cheaper than the commercial Maltino or Barvelt. And in fact, now it's the only glaucoma drainage device approved for use in Indonesia because of its cost, although I'm very impressed to see the low cost of the Aurolab device. And we are following up as many of the subjects as we can to check on the efficacy of the device. The other, you'll see one of the tubes on the lower left picture inserted. And you'll also, we have started doing pediatric, so childhood glaucoma patients with this device. Next slide, thank you very much. Perhaps we've finished. Is there another slide?
That is the last slide.
Oh, that's the last slide. Thank you very much. So it's, from our perspective, it's been very pleasing to see how it's relatively easy to teach surgeons to use this device, because the surgeon just has to create a limbal incision in the conjunctiva with a corneal fixation suture, a bit like a trabeculectomy, which most of the surgeons can do. So the expertise and the skill set is similar, and then with a little bit of dissection, pass the device back into the quadrants, suture it down, and then enter the tube into the eye. And sometimes some of them are using donor sclera and some are not, but the results so far are reasonably good. We hope to have some published data in the near future. So this was basically our attempt to scale up the availability of glaucoma drainage devices, but also make the scaling up of the surgical expertise for glaucoma drainage devices across Indonesia. And the other main aim was to build some significant research capacity. This was the first medical device patented in Indonesia, which has been commercialized in Indonesia. And Dr. Octariana and I won an award for the invention in 2019, but mainly because it's the first medical commercialization that's occurred in Indonesia. So thank you very much.
Yeah, thank you so much. Thank you very much, Professor William Morgan, for your wonderful presentation and the innovation you presented with all the results. Now is the time for a question and answer. Now we have some questions here. First, I would like to go to the Sriram. Maybe I will ask a few questions at once, and then you can systematically answer, because we have a limited time now. The first question is a cost, is about the cost of the implant. Could you please be more specific? This implant surgery compared to the trabeculectomy surgery cost-wise. We know the effective efficacy, it has a better efficacy. The second question is will be on the efficacy of the Auroprost drop when it is not refrigerated, put in the normal temperature, and then the in our part of the world in a higher temperature. Will that affect in the efficacy of the drugs? Another thing is there any additional surgical skill required for this Aurolab aqueous drainage implant compared to the traditional trabeculectomy surgery? So there are the three questions for the Sriram. Now we can see here. Could you please go ahead?
Yeah, thank you, Mr. Sapkota. The price in India that we are selling is somewhere close to about $40 in India in terms of dollars.
Okay.
But when it gets sent to other countries, there is a freight cost, import duty cost, and all of that. So I really don't know the price in the other countries, because it is sold in about 100 countries plus.
Mm-hmm.
if you look at the price of the similar Burwell implant, it is somewhere between $500 to $600. So we have priced it more affordably, and I hope it is available at a reasonable price in all the countries. But again, when it comes to the total surgical cost, it depends on the hospital, country, and the competitive position in that market. So from the device standpoint, in India, we are selling to the customers around $40. And the second question that you asked about the latanoprost, when we have it in room temperature, how does the efficacy, is addressed? So we have tested the product. We have a normally all the pharmaceutical companies have to do a shelf life testing. So we have tested the product at the room temperature. We found that the efficacy of in terms of the availability of the drug has not gone down. So thereby we do not see it will be different from a product that is refrigerated. So in terms of shelf life, it has exhibited the same strength at the end of the shelf life. So we believe it is as good as a refrigerated product.
Okay.
The third question with regard to the surgical, it is very similar to the Burwell implant. So the material is flexible. Of course, it needs certain experience and expertise to do the implant. It is not very straightforward. So once they do 2 or 3 cases, I'm sure that the doctors may be able to do. I can tell this from the fact that we are selling in about 120 countries, where we have not conducted any workshop, or we have not done any hand-holding or given a live demo to any of the doctors. So it got accepted in many countries. I'm hopeful that the doctors were able to find the means to learn and implant it in a safe manner. Thank you.
Great. Yeah, great. Thank you so much, Sriram. It's very well described. I think it's very clear to all the audience, all our participants. Now I'll go to the Professor William Morgan. The question is regarding how is the availability of this Octarian device implant in other country now? This is a commercially available at the already introduced commercially. And then also the second question is, here comes also the surgical skills again to you. Is there any additional surgical skill required for the people who normally performing the trabeculectomy surgeries? Professor William, please.
Oh, thank you. So at the moment, it's only available in Indonesia. It is manufactured by a Japanese subsidiary called Roto, who also make intraocular lenses. They're looking at exporting those devices potentially to Vietnam and some surrounding Southeast Asian countries. But as far as I'm aware, I don't think it's yet being exported. But because of COVID, I haven't been able to get up to Indonesia for about a year. And so I'm not quite sure where they're up to with the export there. In terms of the surgical difficulty, if you like, of the surgery, it's quite easy. That was one of the design briefs. So you don't have to sling muscles. It's longer rather than wider, and so there are no wings. So for example, with the Barvelt tube, there are wings on it, and you have to place them under the muscles. Whereas with this device, you don't need to worry about that. So the surgical technical side is relatively straightforward. I think the big difference between any of so this is another non-valved glaucoma drainage device.
Mm-hmm.
We recommend to our surgeons that they tie off the tube with a vicryl suture, and then about 6 weeks later it dissolves. And it's the management of the tube post-operatively, which is different to managing a trabeculectomy. And that's probably one of the learning curves, I think. It's not just the surgical technique, but it's also the post-operative management that's has to be learned also. So we've, in Indonesia, Dr. Werner Octarian has had a very thorough set up a very thorough program for training other surgeons. And that seems to be going quite well.
Yeah, thanks, William. Yeah, I think you partly answered. Another question pop up here. How about the post-operative follow-up? Does it has to be follow-up as we normally do for the trabeculectomy surgeries? Or is there any better or the shorter follow-up we'll do with this implant?
Well, look, it's similar. Often the pressure drops over the first few days after surgery, and then often it will rise until the stitch around the suture around the tube dissolves, and then it will fall again. And then the patient will go through what we call a hypertensive phase at about 2 to 3 months post-surgery. And you often have to treat the patient with pressure-lowering medications. And then it actually takes probably 9 months to fully settle down. So the patient will form a fibrous capsule around the plate. And it doesn't matter what the material it is made out of, it's pretty much the same. And then at about 9 months, the vascularity of that capsule has minimized and the flow is optimized and the pressure is generally about its best, and it usually stays relatively stable after that. So that's different to a trabeculectomy, where usually the first week you're watching for hypotony, and then after that it's become smoother. So with one of these glaucoma drainage devices, generally you've got to watch them a little bit more closely for longer, and you can expect some problems at about 3 months, which you don't tend to get with a trabeculectomy. But the payoff is after 9 months, where you usually get a much more stable intraocular pressure for a lot longer time course. And the best papers are really those by Anthony Maltino, and also the tube versus trabeculectomy study for people if they want to look at those.
Yeah, thank you so much, Professor Will. I think there are more questions, but I think we have a limited time here. I will end up the question and answer session now for this first session of the presentations. Thank you so much, Sriram, and thank you so much, Professor Bill, for a wonderful presentation. There are more questions, and we'll be sending you an email, and then hopefully we'll get an answer from you, and we'll send to the participants. Now we will enter to the second session now. The second session, I would like to invite Dr. Indira Paudyal from the Nepal, talking on her experience and expertise on the glaucoma awareness campaign in Nepal. Dr. Indira Paudyal, please.
Good morning and namaste. Today I'm about glaucoma awareness in Nepal. So in this first slide, I have two posters. One is the World Glaucoma Awareness Week, and then the other is what we followed in Nepal long time back, started in 2004. So glaucoma, as we know, it's an irreversible blindness worldwide, and the number of people with glaucoma increased worldwide. And in Africa and in Southeast Asia, it's going to be 11 million in 2040. So the challenges in developing countries, like in Nepal, only 2.4% of survey population had awareness of glaucoma, and among those who were aware, only 45.5% had knowledge of glaucoma. So the awareness of glaucoma in Nepal, as well as other Southeast Asian country, I think it's quite similar, and many of the disease is missed because it's underdiagnosed. And this is a slide showing the survey, that national survey in 1981, and the RAB in 2010, almost 3% of glaucoma blindness to 5%. And challenges in developing countries, the poor infrastructure, inadequate human resources, and the less number of ophthalmologists that we have in a general public. So glaucoma is it is a public health problem, but lack of awareness and knowledge about the disease among the general population is a big question. Being a public health disease, many are unaware in our part of the world. And delay in diagnosing glaucoma, it's a silent killer. So we don't know when we are losing our sight until we get blind. Nearly 90% of glaucoma cases are undiagnosed in developing countries, and majority of patients have severe disease. It's mainly because the concentration of ophthalmologists is in the urban area, and distance is it's an important factor here in Nepal to reach a doctor, eye doctor, and huge financial burden. And in a study from India, the average cost of glaucoma drug alone ranged from 13% of the monthly income. So it's pretty challenging. So in Nepal, we follow the LVPI pyramidal model for eye care delivery and similar model for awareness of glaucoma. So in primary level, training of the middle level people, ophthalmic personnel, where we lack ophthalmologists, and we establish primary eye care centers. So that will lead to reduction of expenditure, traveling, and reaching the cities for treatment. And this is what we did for awareness. So to create awareness in the community, or to create awareness amongst the healthcare professionals, we organize trainings for the ophthalmic assistant. We published a book for them in a simple language so they could understand the basic of glaucoma. And at various tertiary level, secondary level, and at the secondary level, we had the ophthalmologist, and and majority of the diseases have to be seen by ophthalmologists, but in Nepal, it's not possible. So to the community level, we had to go and do surveys, and we had to teach this ophthalmic assistant. So primary level cataract outreach programs can be used, like opportunistic screening of glaucoma. Our cataract programs are very effective in Nepal. And in a study on opportunistic glaucoma detection during the community-based cataract outreach program, 3.37% in population more than 50 years had glaucoma. So this also raised awareness in the community. So throughout the year, we do more than 30 camps from Tilganga Hospital, as well as many other hospitals of Nepal. So this will be a very useful tool and a useful model, to detect glaucoma. And at the secondary and tertiary levels, they are producing ophthalmologists to be deputed in the secondary levels. And Tilganga is a pioneer institute in Nepal in training glaucoma fellows. So to create awareness, we also need a good human resource. So most of the glaucoma specialists, they work in various parts of Nepal. They are trained, to organize awareness program and awareness week and community awareness program. So we stressed in that, and glaucoma fellowships in Nepal started in 2013. So in 1981, we had only 7 ophthalmologists in the country. And 2011, it went up to 150, and 2021, it is 388. But glaucoma specialists in 1981 were 0, and 2011, we had 3 glaucoma specialists. And after this program, we have more than 30 glaucoma specialists. So this created, a lot of awareness in the community, and the hospitals are able to have glaucoma specialists. And first public awareness week, we started back in 2004. And here we created awareness of glaucoma, the importance of screening the families, and distributing free medication and enrolling people for free surgery. So this made us bring families, family members who are diagnosed with glaucoma to come back at least once a year to receive free services, and we were able to detect glaucoma. And so patients were, were counseled, and we at the secondary level, we again did this glaucoma awareness week, and we found that when we were screening and doing this awareness, we found nearly 7.6% of total registrant to have diagnosis of glaucoma at the first time. And also we created patients handbook and created glaucoma support group back then in 2003. And the objective of this glaucoma support group was, again, free education program, promoting glaucoma awareness, financially supporting poor patient, and we financially support a poor patient throughout the year for their medicine and even for their surgeries like trabeculectomy or tube shunts or even cataract surgeries. So this education group, once in two months, we give classes to our new patient so that they will understand glaucoma and they will create. So the impact of glaucoma support group Nepal and awareness program has played a various role in promoting awareness, and there are various challenges: our aging population, the geographic terrain, limited human resource, poverty, literacy, and the glaucoma disease itself.
Sorry, it's Bill. I'm caught up in a meeting, unfortunately. It's a Zoom.
And screening is also cost. The tools for screening and case detection. So opportunistic screening and potential role of tele-ophthalmology. So we did a iPad visual field study in Nepal, and also the picture camera, so that we could hand this to our ophthalmic assistants in the community level for screening glaucoma and then creating awareness. So in conclusion, I'd like to highlight what we know. We know that glaucoma blindness will increase with aging population. So we need to focus on opportunistic case detection rather than large population screening, encourage case finding in first degree relatives. Again, this has to be done through awareness. Like right now, we are having our World Glaucoma Awareness Week from 7th March to 21st March. So in this, we aim to bring families of already known glaucoma patients. So we can create awareness among the patients, give them free service, and also detect glaucoma. It is always wise to detect glaucoma when there is early disease. When it's advanced, we cannot do anything about it. So just increasing awareness is one of the prime options to address the challenges in detection and management of glaucoma in Nepal as well as Southeast Asia. So recommendation for awareness: number one, capacity building. So we need to train more ophthalmic assistants so that they can go to community level where there is lack of ophthalmologist or glaucoma specialist. We need to train optometrists to detect early glaucoma. We need to train ophthalmologists to detect glaucoma and to perform trabeculectomy. So a patient who cannot travel to tertiary hospital to find a glaucoma specialist can get treatment there. And glaucoma specialists, we still need to increase in our country. And also the disease is missed in many parts. 50% of the disease of glaucoma is missed in other countries as well. And formation of glaucoma support group is needed to create awareness, to create delivery of service to the patient. And we need to prescribe cost-effective drugs. Like, I'm very thankful to Oral Lab. We don't have to ask our patient to buy a refrigerator, when they can't buy medicine. So this is a very big step. Promote telemedicine for rural areas and conduct frequent glaucoma awareness program at primary, secondary, and tertiary levels. So with this photo, I want to say that we are very successful with cataract, taking care of cataract patients, and our cataract surgical coverage rate is also going up. And this is a photo, I myself, being a high volume cataract surgeon, these patients are all waiting for their vision post of examination, thinking how much I'm going to see. My vision is going to be clear, or I'm not going to see. But then I still have a doubt whether they know, do I have glaucoma? Thank you so much.
Thank you so much, Dr. Indira Paudel, for your wonderful presentation and the innovative model and the method of the awareness creations and bringing down the glaucoma diagnosis at the community level. Thank you so much. We'll come up with the questions later after the presentation of Rasima. Now, may I invite to the Dr. Rasima Asokan for her presentations that the community model and the optometric perspective of the glaucoma screening and bringing down to the grassroots level.
Thank you so much, sir. I thank IAPB Southeast Asia for giving me the opportunity. to talk on the steps for sustainable and affordable glaucoma care in the community setup. This is from the optometrist perspective. I first of all thank Dr. Indra, who has covered the almost everything about what an affordable care in glaucoma should be. So my talk is going to be very simple. So we all know that the prevalence of glaucoma is actually increasing with aging and the disease is progressing faster. So we, as an eye care professional, should be able to diagnose the condition at an early stage so that we could actually increase the longevity of good sight for the patient and we reduce the burden of the disease. So we should be able to equip ourselves in early detection stage. So what as an optometrist should be doing for glaucoma is what my talk is going to be on. So these are the lessons which we learned from the Shankarnetra alias Chennai glaucoma study, which is a large epidemiological study. From that, we had actually taken up few lessons and we have incorporated that in our community. So I'm going to expand that to the India level community eye care setup, mainly the optometry setup, what they should be equipping with. So why the patients are a bit scared of this diseases, because they are very anxious that their entire life is going to be blind, and they're also scared whether they have to be dependent on someone till their end of late life. So that is what is making the patients worry, right? So we should be in a position to make sure that their good sight is preserved. So only thing which we could do for glaucoma is detect them at an early stage. So the steps in glaucoma evaluation includes this. Everyone knows that. I'm just going to refresh that. So it includes a comprehensive history taking whereby we can actually identify people who are at risk, and also clinical signs from the anterior segment evaluation, intraocular pressure assessment, and the angle assessment. If we do these two things at the community level, we will be able to pick up the conditions at an early stage, and we can actually refer them for the higher examination, which could include the structural assessment using a optic nerve head photography or using a diagnostic tool such as an OCT or an HRT. And the most important thing is we have to assess the functional visual loss using a visual field, or otherwise sometimes using the electrodiagnostics tool. So the 4 steps includes a comprehensive examination for glaucoma, but whatever possible we could deliver at the community level, we should be able to take that in our practice, and we should be able to deliver that to our patients in the community. So this is actually the indicators what a primary, secondary, and tertiary care should be focusing on for glaucoma. So with that, in the primary, a person should be equipping with a slit lamp with an applanation tonometer, able to evaluate the angles, able to evaluate the optic nerve head using a non-mydriatic fundus cameras, and also create awareness among people, create awareness among the co-workers, create awareness among the other eye care professionals and general practitioners, and also appropriately refer them for the tertiary care. So not only this, with the COVID-19, I think every one of us are into tele practices now. So with glaucoma, I think it is important to adopt the teleglaucoma care into our stream so that we can actually reduce the load of burden to the ophthalmologist. So when we screen for glaucoma, whatever be the screening, it should be 85% sensitive and 95% specific. In that case, if we have these packages of the test like Van Herrick grading, non-contact tonometers with a fundus imaging with an automated detection softwares and visual fields such as FTT in practice, we will be able to diagnose the conditions very effectively because they all have a good sensitivity and specificity. So I'm going to give you a few tips which you could actually have it in your clinic. Having a handheld slit lamp to screen in a community, you will not be able to carry the whole table mounted slit lamp. So having a handheld slit lamp, diagnosing the anterior segment changes, not only for the primary conditions, also the secondary causes like pseudoexfoliation or a neovascularization of the iris, which will actually give a clue whether there is a cause for a secondary disease or not. So that also should be kept in mind. And also to evaluate the Van Herrick, because you're going to pick up the angle closure, which is actually high prevalent in our community, and people with suspect for occludability is going to be high. So we have to be evaluating the Van Herrick and then going for the gonioscopy or the tertiary care referral. So doing a small one-hit grading actually picks up the condition very early. Having a non-contact tonometer in a community, it actually measures the intraocular pressure just like that. So it gives a clue whether there is a person is at risk for the glaucoma or not. So you can actually better explain to the patient about the condition and ask them to go for the referral. So this is what I feel has to be there with every other clinic now. Important thing is the structural assessment. I think more than having an equipment, we should also be in a position to diagnose the condition. So we should be equipping ourselves with the training for optic nerve head evaluations. There are multiple training modules which are available for optic nerve head evaluation for glaucoma, which is also available as an online resources. If not, the optometrists in the tertiary care center should be taking up a role of trainers in training the optometrists and opticians across the country so that they can well diagnose the condition. So having the fundus cameras, which is non-mydriatic, there are multiple cameras in markets now. We could actually adopt one and make sure that you go to the community, take the photographs, and you can actually send it to the ophthalmologist and find out whether the person needs a referral or that is just in wait and watch condition here. Having said and done with the fundus cameras, we can also have a structural evaluation using application softwares, which also give some values like cup disc ratios, what is the neuroretinal rim. But all these things will actually help us to follow up the patient so that you know if there is a subtle change, refer them for the next care. Dr. Sriram and Dr. Bill were talking about the advanced technologies which are available now in market. So likewise, the smartphones with and add-on packages are also very handy now. So you just need to take a phone and then go to the community, take the pictures. With these add-ons is actually amazing because we have to go to the community to diagnose the conditions. If you have a very limited resources with you, even a smartphone is going to help you. So I'm going to just give an example of a DI app, which could actually be linked with the electronic medical record. So patient details are also saved, and you can actually ask your ophthalmologist to take a look at the fundus, and then they can tell us whether the person needs to be referred to the hospital or it could be managed at that community level itself. Last but not the least is the visual field screening, because we know that glaucoma also affects the visual field. So we need to have a visual field screener along with the fundus cameras, which is going to be a very good tool for diagnosing the condition at an early stage. So having an FDT or with the innovative technologies, the virtual reality based visual field screener will help us to have a baseline evaluation about the visual fields. And if there is any defect noted, we could actually ask the patient to go for an immediate care. So this is what we have to be practicing. And with COVID, everyone are actually very familiar with the telemedicine care. For glaucoma, this is going to be really an effective tool. So if we actually increase our telemedicine practice, then it is going to actually make the ophthalmologist to take a lesser load because we can actually take their opinion over the call or over sharing the images. So having the vision screening, anterior segment evaluation, IOP estimation, posterior segment examination, visual field examination, and sending the reports to their ophthalmologist and get their opinion about what to be done for the patient next is going to be the next tool which we have to be practicing. Okay, so having said that, we should also be in a position to know what is the referral pattern. So this is one which has been adopted from Canada. I think IAPB and WHO should also come out with an extensive referral plan for glaucoma because they're all focusing on cataract screening. In the comprehensive eye examination, we should also focus on glaucoma evaluation with a clear guideline for referral. In that case, everyone is going to follow the same pattern, and we can actually reduce down the burden. So not only about the diagnosing the condition, it is important that we penetrate about the disease prevalence and also the progression to the community. So we need to create the awareness, and also about the medical management. We should be tell them about how compliant they should be with the drugs. If the compliance is not going to be there, whatever efforts which you put down is going to actually reduce down the importance. So it is important that we have to create an compliance assessment for these patients So this is one picture which we have taken from the Chennai glaucoma study, where we have been telling about the condition to the people. And you should see that even the awareness about the glaucoma in the urban is very less. And so only as the eye care professionals, we have to increase the awareness so that they will be very compliant with their medications. So we know the WHO 7-step approach, but I'm just going to put that we have to be involved in opportunity screening and create awareness to the public and also to the our colleagues about glaucoma and importance of glaucoma management. And we also should follow a disease-specific guidelines and engage the primary healthcare professionals with us in diagnosing the conditions. More importantly, have a practice of teleglaucoma care, which is going to be a routine from henceforth. So together we can actually tackle the solution for glaucoma. Thank you so much. I'm open for any questions.
Yeah, thank you so much, Rasima, for your wonderful presentations. And then the technology and the skills we can bring down the glaucoma screening or early detection to the community level, successful model, and then all the suggestion for the awareness. Importance, highlighting the importance of the awareness. I mean, now we have a question and answer sessions. Now the first questions goes to the, I think is more appropriate to the Dr. Indira. So since you are using a lot of community screening program and the opportunistic screening program in the other purpose of the eye care activities such as glaucoma, cataract and the other camps. So what is your diagnostic criteria for to diagnose the glaucoma in those community screening setups?
So when we do the community opportunistic screening for glaucoma and cataract camp, so we have a resident and they are a consultant doing the camp. So we have a resident, who look at the disc of the person whose media is clear, and if there's any suspect of the disc, and they record IOP with the help of tonometer and eye care, and frequency doubling perimeter was also taken. So with these, it's very difficult to make a clear-cut glaucoma diagnosis. So we used to bring patient to nearby hospital where we have the facility of the slit lamp, and then do a Humphrey visual field, and then we make a diagnosis. So the opportunity screening was effective for camps which were near to the hospitals, and where we have our community eye centers. In community centers also, we have the facility of we could examine, the resident could examine, or they could be referred. So this prevented us, someone who lives in the mountain and just the IOP is high, taken by ophthalmic assistant there, or a suspicious disc, they end up traveling 2-3 days, from the mountains, and then when they come to a tertiary hospital, we say, oh, you're just a glaucoma suspect, you don't have to show. So that made us develop the telemedicine. So we practice the telemedicine now.
Okay. Yeah, thank you so much. I think the another question for you is regarding the awareness. You in the both presentation, Rashima, and you presented that there was a very low level of the awareness among the glaucoma identification or on the glaucoma, knowledge on glaucoma. So with your successful intervention, all these efforts in many years, do you have any data to present that it has bring up some changes in the level of the awareness in the community?
So that awareness data was from our Bhaktapur glaucoma study that we concluded in 2010. So we still haven't, done another awareness study. So in hospital, we do, in a hospital-based study, that we do awareness programs every 2 months. So 6 classes we take for a glaucoma patient or whoever is interested in our hospital. And then we have filled up some forms. So to the patient who come to the class in the first class, and at the end of, at least we call them for 3 to 4 classes consecutively, we have found that when they enter the class, they are not sure about the disease, even though they have the disease, putting drops for a few months or a few years. So at the end of the class, we have found that there were some 15% awareness, but this is just a hospital-based study. We haven't been able to do a larger epidemiological study like the Glaucoma study.
Okay, thanks. The next question goes to Dr. Rashima. You mentioned in your presentation that the technology and the skills with the appropriate technology and the appropriate skills of the optometry has acquired will be able to diagnose the things in a community level. The glaucoma can be diagnosed. So, but it is evident that the eye health provider system in many of our country need to adopt this kind of the task shifting from the ophthalmologist to optometrists or ophthalmic assistants or the whoever mid-level other ophthalmic personnel to detect the glaucoma at the primary or the community level, and then embed the system and the recognition of their work. So what is your experience in India? And then since you belongs to one of the biggest reputed institute where the production of the optometry in India or in South Asia, what is your, could you please reflect on your experience on this task shifting system or adaptation of what you have talking in the Southeast Asia region?
Thank you, sir. So we belong to the one of the large the epidemiological study where we found that many of the optometrists also are not aware about how to diagnose the conditions, though they have actually qualified as an optometrist. And we actually did a study to know whether there is a willingness for them to learn about diagnosing the condition. And we out of a surprise, we thought 95% people were actually wanted to increase their knowledge, which means there is a large pool of people who wanted to actually acquire the skills. So what we did is we did many training programs. We conducted many CMEs where we invited optometrists across the country to learn about the technical skills on IOP estimation, technical skills on fundus imaging and how to diagnose for glaucoma. So many of them were very happy and they actually had put that into the practice, and they used to send us the picture saying that I was very happy because I diagnosed the patient with glaucoma and I referred to the ophthalmologist, and the ophthalmologist was very happy that I actually picked up at a very early stage. This is what we wanted. So we want to increase and expand this CME programs across the country so that we could actually provide a sustainable care for glaucoma, because as one institute, we will not be able to tackle the whole nation, right? So we need to actually spread our knowledge to the country. So where we want to increase the CME programs and invite many of the optometrists to come over and get the training, get the hands-on skills, and then use that into their practice. This is what we are aiming at, and we do think that this will be done across the country.
Yeah, and how about the task shifting? This work is mainly done by ophthalmologists in many of the countries in our region, where the optometrist and the ophthalmic assistants work are not recognized for diagnosing such conditions. So for those, you have any experience or anything to say?
Yes, sir. So if you look at the ratio of ophthalmologists and optometrists, it is actually 1:9,000, which means the number of people whose optometrists are actually more than the ophthalmologist. So the ophthalmologist cannot go to all the sectors and diagnose the condition, right? So they can actually train their optometrists and put across in different places so that they can get the referral of these patients back to their hospital. And they will not be overloaded with all the patients, because if they have a telemedicine practice also into it, their number of patients whom they are going to see is also very less. And they also make sure that their care is delivered by the optometrist sitting in a different corner of the country, right? So this is what we want to promote, and we feel many of them are adopting it, and many optometrists who got trained from us are actually expanding this in the country.
Yeah, great. Yeah, thank you so much for the so well descriptions on this awareness and then the optometry perspective, and also for Dr. Indira for the awareness and the successful example and model presented in the Nepal. So since we have a limited time, the more questions are there, but I will come back to your question with the emails, and then you please answer the email to us, and then we'll send to the participants. Now, I would like to go to the Mr. Suresh Pattathil for your concluding remarks, sir.
Yeah, thank you so much, Dr. Yoda, and I want to really congratulate the earlier speakers because they have really touched upon a lot of very important things like use of technology, bringing in affordable solutions for the patient, including I think the key which sort of struck me was about the lack of awareness of glaucoma in urban as well as rural centers, and I was very happy to see the kind of work which was done by both Dr. Rashima as well as Dr. Indira. Now, I want to go back to some of the data which is there, and it's almost 0.8% of the Indian population suffers from glaucoma. And it's a very, very minute number of them who are diagnosed and treated today in India. And looking at the IAPB data, which was released on World Sight Day, moderate to severe visual impairment in India doubled from around 41 million to 79 million people from 1990 to 2020. So in 2 decades, it's almost doubled in number. And then going back to another data which was released by the National Blindness and Visual Impairment Survey between 2015 and 2019, almost 93% of cases of blindness among people above the age of 50 could have been avoided. And a large number of them are because of glaucoma. So glaucoma is one of those silent disease, especially the open angle glaucoma, which will probably not be detected or treated. So now Allergan, which is now an AbbVie company, has been in the forefront for more than 70 years, bringing in new products and development for the treatment of different kinds of ophthalmological disorders. Now, where we have been working on for the last many years has been upskilling or providing skills for general ophthalmologists to detect and treat glaucoma better. Because the first stop for any patient is actually the general ophthalmologist. And now it's appropriate that they should be able to diagnose and treat glaucoma properly. So that's where we have been spending most of our efforts in terms of continued medical education over the last many years. The second, which we have also was in partnership with IAPB and Sightsavers, we have also done community screening in Orissa. I think just before the COVID, we had already screened around 13,000 of the community members in a town. And out of that, around 400 to 500 of them were found glaucoma. They've detected the glaucoma. So but that's a very small effort, in a very large country, I would say. So that's one of the other things which we have done. And the other one was also providing continued medical education for the glaucoma specialists itself on the latest technologies. Now, however, what we have taken up as one of the leaders in glaucoma treatment is we are looking at how do we improve disease awareness, glaucoma as a disease among the lay public, among the urban population. And I was very surprised to see that even among the urban population, the glaucoma awareness is so low. So we are looking at using the digital medium, like Dr. Rashima said, you have the iPhones and you have web connectivity. So you have a large number of the population connected through digital. So we are embarking on a program in which we are trying to educate the lay public on glaucoma and the need for early detection and treatment, which is the key to prevent blindness in these patients and increase diagnosis. So this is something which we will be starting now and probably will be there for the next couple of years because it's not going to happen in 1 year or 1 month. So that's where we will put in a lot of efforts in terms of as a company in focusing on disease awareness and getting the patient to go to the doctor or going to an optometrist or going to a general ophthalmologist for seeking treatment or, at least checking their eyes. That's one thing which we will be definitely, and hopefully what we will do is, we will have some impact on reducing the number of blind above the age of 50, which is going to be a burden on the country in the long run if left, not addressed. So this is what I want to share with everyone. Thank you so much for really presenting a lot of the new technologies which are available as well as the affordable solutions. Thank you so much.
Thank you so much, Suresh.
Over to you,
wonderful.
Dr. Yoda.
Yeah, thank you so much for your wonderful concluding remarks and then your activity and then your partnerships with the IAPB and the Sightsavers, which has gone very wonderful way in the South Asia, in the India, and the many countries in Africa, of course, I know. Now, I think we are at the end of the this session in this webinar. The wonderful, I would like to thank you so much for the wonderful presentation for all the speakers, so useful, so fruitful, and then we have come up with the suggestion and the recommendations of the many sustainable solution, which is many of our innovative and the successful examples were presented and showcased in this session. So thank you so much for all the speakers. Now we are at the end of the session. Now go back to the Debbie.
Thank you, Yuda, and thank you, a big thank you to all of our speakers today. I'd just like to remind you all this webinar is available to watch again via the Facebook page, and also will shortly be posted on the IAPB YouTube channel. So thank you to everyone for joining us once again, and we'll now end the webinar. Thank you very much.